Hello, everybody, and thank you for this opportunity to present some of the work that we've done around the evidence informed policymaking space based on the ongoing works we have in two counties in Kenya. The title for this presentation is The Inherent Politics of Public Health Evidence Based um, Policymaking in Kenya, which gives a synopsis of our experiences so far dealing with different stakeholders on matters policy from the perspective of counties, especially counties in Western Kenya. And this lovely photo that starts us off shows as stakeholders that we've had interactions with from a political space, showing leadership from one of the counties, that's in Bungoma, and leadership from our project team, as well as some of the key members of our team that have been involved in some of this work. This project is made able by the World Health Organization, specifically the Alliance for Health Policy Systems Research, on a grant given to Ampath and Moi Teaching University, Moi University. But specifically, the key members who are vital to this are the members of the county health management teams and the county leaderships in the two counties of Bungoma and Busia, as well as my institution, that is United States International University, Africa. A quick background, just to mention, the current space of public policy making in Kenya is defined by several interconnected phases of interaction between politicians, researchers, and various institutions that carry out research in the context of these counties, various practitioners from health managers in counties, and technocrats from a variety of sectors, as well as knowledge brokers and interest groups, specifically grounded around maternal child health. So the devolved health system in Kenya has indeed greatly expanded the participation of communities, availability of health services all the way to the county level and community level, um, and also improved county-specific sector priority setting, budgeting, and planning. And this has come with its own intricacies. Incorporation of different stakeholders who previously did not have a role in the process of maternal child health delivery. So our study specifically followed this process of the current policy-making space. Is it informed by evidence? What are the challenges and who are the different stakeholders and players, especially focusing on the priority needs in these counties of maternal and child health? So our key objective was to describe, elucidate the politicized and highly complicated processes of policy and decision making in two county governments in Kenya. And the two had very similar barriers, facilitators, different contexts, however, but the players more or less had the same value system and more or less which ended up complicating the process of evidence-informed policymaking and decisional capacity. So to describe this, we leveraged on an integrated capacity framework to describe various organizational resources that are needed for delivery of maternal child health services, structures, competencies, and supportive factors in policy coordination and mechanisms around policy reviews. Using a Delphi technique, we then qualitatively explored past and current policy values around the key stakeholders within the Department of Health, critical to answering the questions on what are their individual, what are their political, and systematic or systemic factors that influence county health policymaking. And then using in-depth interpretive approaches, we assess the barriers to evidence-informed policymaking and service delivery. Admittedly, again, the political and systemic factors that influence decisional making and policies are very intricate, with fragmentation of decision making, some of which would lie solely with political figures such as county health assembly members, or some of which would be held with a county director of health, some of which would be extended to higher leadership. Just to give a practical explanation as how this was done, we established a sign-up committee, which refers to a Science for Policy task force committee that was comprised of various members, technical members within the county health management team, which manages all health activities in the two counties. So in each county, we established a sign-up committee with diversity at the center of it to ensure there was a holistic approach to how governance, research, policy integration was carried out, as well as capacity building, stakeholder consensus and engagement. And these were the key anchoring pillars of the Sign Up initiative. The committee was comprised of members of diverse decisional capacity from policy, research, maternal and child health, with a minimum composition of 11 members and a maximum of 15. So the key guiding parameters, key guiding policies and principles were they would hold relevant maternal child health policy conversations, work within the larger project team members to facilitate strengthening of knowledge systems, processes, and also identify good policy on good health practices that leverage on contextual evidence to inform policy, support policy formulation and implementation of these policies. Now, this practically entailed regular conversations with research organizations, academic institutions, and various other players in this health sector who had ongoing projects, ongoing implementation activities around health. They would also have a culturally adaptive framework based on national policy guidance all the way to the national, from the national level to the county level. Now, they would use advanced communication skill sets to also communicate contextually relevant priorities ethically, especially to leadership, where decisional capacity was held. They would also ensure this trust and openness in policymaking spheres, and policymakers and scientists would come together to co-define research questions. The key findings, especially from the higher up executive, is more or less alluding to county leadership. We found that primary authority and operationalization of most of these um, sign-up task force activities, which revolved around evidence-informed policymaking, were made by the executive. The executive, in this case, would be the county governor and his county health assembly members. We also found that they had a role to play in review and support of implementation of policy items by ensuring that the relevant resources are available, by ensuring that we have a dedicated pool of human resource, and also ensuring that the overall leadership and governance came from this executive team. There was also approval of the sign-up task force charter, which was a whole document that entailed a different role and repositioning different stakeholders to ensure that the decisions that were made, the resources that were made, especially maternal child health, followed in line with the guidance of the EIPM, or Evidence Informed Policymaking Checklist, which outlines different domains and how we can build their capacity from governance all the way to various health service delivery points. They also supported the EIPM, or Evidence Informed Policymaking, whether through policy reforms, policy dialogues and forums, and also supported the overall sign-up project. Some of the key findings qualitatively indicated that at the county level, policy ecosystems indicate or show a fragmentation of decisional power and inefficiency, especially in research to policy dialogues, which entail having regular conversations with research that is coming out of these counties, with the people, the research generators, having a conversation with the policymakers. So such as this from one of the county health managers in Bungoma, saying that the county level decisional making is not informed by data and research. They also say that they lacked an evidence repository of research in the county to show what has been happening among its people and whether they actually offer policy directives, policy recommendations, that is. The evaluation of health systems domains in maternal child health services also showed or indicated significant gaps in responsive action-oriented policies. However, the key silver lining is that we have county leadership commitment to ensure that sound maternal child health policies are instituted. And this is one of the key deliverables we had from one of the very successful maternal child health summits we had in one of the counties. So this is just, and from this narrative, it says that, this is not just about documents and policies that we pass. It's about changing the mindsets, alluding to changing the mindsets of stakeholders in health, equipping institutions and creating systems, health systems where policy is not just reactive, but responsive. And from our perspective, we thought this was a very powerful statement made by the county governor, showing leadership support, which goes a long way to entrenching evidence-informed policy making and decision making in these counties. So from the findings, the key gaps in evidence-informed policymaking included, from a governance perspective, there was a fragmentation of decisional capacity, especially in resource allocation, whereby different stakeholders wanted to play a part in how these resources are aligned and allocated. And this implication would be there is a need for a cohesive and contextualized policy making infrastructure and structure in these counties. From stakeholders' involvement perspective, we noted an inefficiency in the research to policy dialogues, and the implication would mean that there is need for establishment of these regular research to policy dialogues or research dialogues within the county structures with research organizations that operate or have different interventions running in these counties. From a systems thinking perspective, within the evidence-informed policymaking domain, then there's a lack of responsive action-oriented policies, even though contextualized from the national level. But the contextualization of how this evidence-informed policymaking is a key need in all these counties. And in conclusion, we noted that there was a general lack of cohesiveness and togetherness and contextualization of national policy integration in these counties. We need to ensure that we have constant regular encouragement of adoption of scientific citizenship as a standard practice in policy decision making, as well as ensuring that communities are involved in how decisions are made and how policies are made by going back to the people and having regular conversations, such as what we did within the Maternal Child Health Summit, which had close to 40% community-only representation. So what's next? We hope to continuously create robust mechanisms for improving scientific citizenry, better involvement of communities in policy-making frameworks, co-creating responsive evidence-based policy ecosystems within counties, and then ensure that these conversations go all the way up to the national level to document lessons learned, best practices, and see what gaps exist in the current policy-making frameworks from the national level. For regular policy dialogues, we hope that we continue ensuring that research organizations, research institutions, evidence generators in perspective, continue talking to policymakers in these counties and ensuring that they use some of the recommendations proposed for generation and revision of policies. Institutionalization as the larger overarching impact would be institutionalization of evidence synthesis and evidence-informed policymaking within county health structures. Thank you very much for this opportunity to present some of our work, and we look forward to questions, feedback on this presentation. Asante.